Hello everyone. Welcome to our monthly webinar. I'm really excited to introduce this discussion to you today. We're going to be talking about strategic workforce planning and how we use simulation to do that. So workforce planning is really a broad topic, so we're going to kind of break it down into a couple different pieces today, and so let's get right to it. So we have two presenters today. Claire Cordeau, my colleague from the UK, is going to kick us off, start talking about the strategic side of things, and then I'm going to talk a little bit about the operational side of things. How do we actually think about workforce from an implementation perspective? So we're going to kind of share the conversation today, and hopefully you'll get a lot out of it. So just a few reminders before we get started. You are on mute, so we won't be able to hear you speak, but we would love to answer your questions at the end, so we're going to save a few minutes at the end of the conversation. So do look over to your right side of your screen. There is a chat panel. If you want to enter some questions in there, if you have anything that comes up along the way, do send those over, and we will take a few minutes and answer those questions at the end. And of course, we are recording the session today, and that recording will be available on the website. You can take a look at it, share it with colleagues, continue the conversation as well on LinkedIn if you have any other further questions. With that, let's jump right in. Claire, do you want to take us away?
Thank you, Brittany. Thank you very much. So what I wanted to start with really was Brittany and I were thinking of useful topics to have this webinar on. And so many people ask us about modelling workforce, so we thought it would be useful to dedicate this particular one to modelling workforce, simulating workforce from a number of different perspectives, and to share some of the case studies that we're familiar with. So we hope it's useful. We want to cover from a number of different angles how simulation can help to plan the workforce. We'll use the case studies both from UK and US, and we'll also cover some how-to software tips, which we hope will be helpful. So when we were thinking about planning for workforce, there were sort of three angles on it, really. One is the high-level angle that you can see described on the left-hand side. That's the sort of more strategic view of workforce, where you're thinking about your population demand, your activity requirements, what sort of activity you might need to be planning for, and then whether you've got the workforce capacity to cover it. And with that, you'll also be looking at the financial angle. Can you afford the workforce? Who have you got available? And really, it's important to answer that big question if you're doing a strategic service redesign, to start to answer some of the queries that you might have about whether it might be a good idea, but it might not be feasible because you haven't got the workforce to carry it out. And sometimes you can change your service redesign ideas just at that very strategic level. The second level is operational, where you're managing your daily operations and you want to match your competence to your task, and you're looking at the efficiency of your individual unit. So you get quite granular about that, and you're looking at staff shifts and who's available when in order to get the throughput. So the sort of thing you might imagine would be, say, your emergency department at particular times of the day, particular days of the week, which can make a big difference to how you're able to manage your flow. And then finally, the other area of workforce, and in my past, I've worked in workforce development and workforce planning, and the thing that we were interested in was in planning the workforce, looking at the leaders and joiners of the workforce, looking at the demographics of the workforce. So if you're planning a service that requires lots of very experienced community nurses, and actually that demographic is getting older and they'll all have left the workforce by the time you put your service in place, you're going to be in trouble. So you need to be able to plan and commission your education and training and look at your recruitment to meet your needs when you have them. And of course, bringing together a whole new workforce to deliver a new service does require a lot of advanced planning, because you can't just train people overnight. So I think there are three very different ways of looking at planning for your workforce, and we want to cover cover all of those. No doubt you can think of other questions as well and queries that you have. So we'd be keen to hear from you to see the sorts of questions you have and if there's angles that we haven't covered here. So I'm going to start off looking at this high level, and I'm going to use a piece of work in progress from Kent, Surrey and Sussex Academic Health Science Network. I'm very grateful to them that they've allowed us to show some of the early thinking that we've put in place with the Academic Health Science Network there. This isn't a finished piece of work there. I'm showing a bit of a demonstration model of the work we're doing, so I'm not showing their real data, just to clarify that. But some of the thinking, which I think is so common to the thinking of a number of different healthcare economies, whether in the US or the UK, is about how you provide additional services in the community that support people so that they're not going to hospital. And very often that's about supporting older people. The services really need to be 24/7, because if somebody has a crisis and it's after 5 o'clock at night, they'll go to the hospital anyway. So it probably only really makes sense if it's a 24/7 service. And the big questions about that is, well, how many people are likely to use my service? Therefore, what capacity do I require? What's the impact on hospital beds if people are not being admitted? And can I free up that resource in order to support my community service? So that's the kind of big questions, if you like, that people are asking. Now, this is the model that we're looking at the moment, and I'll flick over it to it live in a second. But what they're looking at is unscheduled care for over 75s, and you can see here that we've got a pathway which looks at a number of different services and routes in, if you like, to the emergency department. And at the moment, they don't have this 24/7 primary care service for over 75. So what they're looking at is what would happen if they brought that in. And what they're thinking about is, if you have that service, if, for example, a long-term care facility, instead of people routing to the emergency department, went to the primary care service instead, how many people would that be? And actually, for that one avoided admission, would that just be one visit? And they thought, no, probably they'd need to see that person several times. So we've factored that in. So somebody might wait a day, and then they'll end their service. So we're looking at the whole system. We're looking at the demand coming in at the top end. What might happen if, instead of using one of these more traditional services, they now use primary care instead of the emergency department? So I'm just going to flick over to the actual model. So I want to show you a couple of things on this. This is Scenario Generator, which is our whole system population health model that we're using there. Makes it easy just to put in your population and look at the flow through the whole system. So what we've done is we've selected a population which we put into here, and that enables us to look at the way in which our population is going to change over time. So if I want to model this over 5 years, which is what I want to do, I want to take into account how the population is changing, and particularly that older population at the top there. And you can see it's rising quite significantly, so you could expect some additional demand. And what we've done is we said we're just going to take the over 75, look at all the conditions that they might have, which we've taken from our disease prevalence data, and that's going to create a demand into the top of the model here, which is then going to route through the different sorts of services, and we've said that a proportion of them are going to end up in the primary care locality hub. Not all of them, of course, that wouldn't be sensible, but so when we're looking at people who are going to primary care, perhaps in the past 90% of them would have gone through to the emergency department. This is when they come in for an unscheduled care reason. 10% of them would have gone to the assessment unit. We're now going to send 10% from that 90% through to the primary care locality hub. And the same, we've done the same thing for ambulances, so there's a diversion route there, out-of-hours consultations and the care home. And what we've done is we've allocated a cost to the primary care hub, so that each time somebody is seen, it's going to cost £35. We're talking sterling here. And then they're going to wait, and then they're going to come back, and then there's a 33% chance of them ending that episode. And we've also costed the admission step here in the emergency department. And we've allocated a capacity here, so we've got beds associated with this step here, and we've also got staff associated with this step here. And in the first instance, what we've done is we've put in just one member of staff working full-time. So effectively it would be more than one, but effectively there's one person who's going to be on duty for 24 hours of the day, 7 days a week, and we wanted to see what the impact of that would be. So that's how the model works in its construction, and I'm just going to show you some of the results now. So just looking at the increased demand for unscheduled care for over 75s, you can see that's going to go up. No surprise, I showed you the changing demographics, so you could expect that the demand was going to go up. And so the question is, what happens if we bring in a primary care locality hub just for unscheduled care? And what we can see here is this is the emergency admissions. Here's our average occupancy as a result, and you can see the peaks and troughs there over the period. And you can also see that they're using about 50% of inpatient beds available. And that one full-time equivalent staff is being used around 30% of the time. So it's not, you know, they're going to need to keep themselves busy with other things over that period of time to see that to see those people who are now not going to come to the emergency department. So the next thing is people are saying, well, of course, those people who've got a specialist nurse in there who's very experienced with this group will also want that person to be seeing scheduled activity. So let's look at a concurrent planned care pathway, and let's say that instead of that person seeing a primary care physician, a GP, at this step, they're going to go straight to see that specialist nurse. And let's say that some of our outpatient activity, instead of people going to hospital, they're also going to be seen in that locality hub, and it's a specialist nurse that will do it. Now, you know, there'll probably be a lot of detail behind that, and you might want to put different skill mix within that, but this is trying to answer the big question. So we've run that through and looked at some of the numbers, and what you can see now is that we get the average occupancy of emergency bed admissions drops by 20, and this is a sort of before and after of the locality hub. And overall, our inpatient beds are now utilised 58% of the time. And we can see our staff utilisation is 83%, sort of 84% after that first year. If you then try and run it through for 5 years, you can see we get this big queue building in year 3. So that resource works for the first 3 years pretty well. You can deal with the activity that's coming through, but we're going to have to add more staff at that point. So you can then start to test out the different sorts of scenarios that you might want to, the different numbers of staff that would effectively be able to meet your demand. So if you're thinking about making a decision around your staffing requirements to run a new service, you might know in a locality that you do have somebody who can manage that, but it gives you a couple of years to build your capacity to meet the demand when it comes. So that's one example, really, of how you can use simulation to help you plan strategically for your workforce. And I'm going to hand over to Brittany now to look at the more operational view of workforce. Brittany, you're to have control now.
Yep, got it. All right, we'll jump right in. All right. So I want to talk a little bit about modeling operation. So once we've sat down and in Claire's example, right, we figured out we are going to do this this outpatient center, right, for unscheduled care. We know that we need one FTE, right, 24/7. But then the question is, okay, so realistically, when we bring in that second person, where are they going to go? What hours are they going to work? How are we actually going to manage this on a more detailed level? And so what I want to do is talk to you a little bit about three specific examples of how we might need to look at staffing and the kinds of questions that we're going to be able to answer, or we're going to need to answer using our models. So there's kind of the typical questions fall into three kind of categories. The first being the kind of thing that Claire was just talking about when we're evaluating a big change. So what happens if we add a new service? What happens if our volumes are growing, like she was talking about in year 3, right? As our volumes grow, what does that do to my staff utilization? What if we modify a protocol and we change the way we're going to treat strokes, or we have a new tool that a new diagnosis tool that we want to use? You know, how does that impact our staff and our operations? That's kind of the most obvious bundle, and that's where we see the most work with simulation. But there are kind of two other uses that I want to point out. One being roles and responsibilities, and increasingly, you know, we have limited budgets. We want to make sure that everyone is working to the top of their license. We talk about that a lot now. And so the question is, what is that ideal skill mix if I'm opening up a new service, or just thinking, you know, I need to be more effective with my funding and with my budget? How do I balance all of these things? And what is that right skill mix? And who should be doing what, right? Who's going to get assigned which responsibilities? And then finally, the last category is really around that cost management issue. How do I minimize overtime? When do I call in the extra support staff, and when can I get by without them? Those are all kind of key questions on more of a daily basis, right? I'm making those decisions every day. How can I make more effective decisions to manage the cost of running my unit or my clinic, whatever it is that I'm working in? Okay, so when we think about these kinds of questions, there's kind of two different approaches. The first is going to be to actually model your process, right, and use that to estimate my staffing needs. So this assumes that I have as much staff as I need, and if I'm willing to call them and willing to pay them to come in, I have access to these staff, right? So we've kind of taken staff out as a constraint and instead used the operations, right, the process flow to say, how many staff do I need to have? So we model our process, we look at our results and say, you know what, given our utilization, we can probably use 3 FTEs because we're on occasion we're getting to 4 that we'd really like to have, but that doesn't happen very often, so we can get by with 3, right? That's a reasonable compromise. And then I would probably run my model and test some other scenarios, but that's an approach that we can use, right? So we don't even have to model the staff, kind of assume that they're available when we need them. The other approach would be to actually model the staff as a constraint on our process, right? So we put in our staff, we assign them to, you know, their schedule, and then we look at our results and say, given the staff that we've assigned, are these results acceptable? Right? So given that I have 2 to 3 RNs on staff at any given time right over the course of the day, what does that do to my throughput? Well, you know, 240 minutes, that's an awfully long time to be in this clinic. Maybe actually I need to add some more staff if that is indeed the bottleneck. Right? So this kind of is the second approach, actually putting the staff into the model, using them to constrain throughput and patient, and then looking at the results to determine if the situation is acceptable or not, right? And check the different scenarios that way. Okay, so operations, kind of 2 different approaches to modeling them. So let me actually walk you through 3 examples, and we're going to see both approaches. This was the first approach, right, where we modeled the process and then we used that to estimate staff. So we were looking at an operating room. These 3 examples are all projects that I've been involved with in the last few years, so these are real examples. This was an operating room, and patients were struggling to get in. They were experiencing long delays terms of, from the time that they needed the procedure to the time they could actually get in onto the schedule. But at the same time, the operating rooms themselves were sitting idle. If you walked around on an average day, there were rooms available, but yet somehow we couldn't get the patients in. And so really what this required us to do is actually look at the OR schedule, right? And so staffing was going to be an important success factor. We needed to make sure we had enough staff on, but really they weren't the key focus of the project. Actually, what we were looking at was the schedule to make sure that we had structured that correctly. And so what we actually used were the staffing ratios, right? We know that a nurse can prep about 4 patients at any given time. When the patients come out and they're recovering from anesthesia, right, that ratio needs to go down to 1:1, 1:2, up to 1:4 as they get into phase 2 recovery. And so we were able to use those ratios to think about how do we translate the operations staff. So let me actually show you what I mean by that. So this is a version of the data that we actually got out of the model. And you can see on the left, these are the actual beds that were in use. So you've got the red line there, which is the average beds, the average number of patients who are actually in prep at any given time. And then we've got our min and our max, right? And so on really busy days, sometimes our beds were utilized at a much higher census level, and on slow days, right, sometimes your beds weren't all that full. And so looking at this range, what we can then do is use that to estimate staff, right? How many staff do we actually need given this ratio of 4:1? And so on the right-hand side, what we've done is translate, okay, so let's say at 6 a.m. our average census is 6. Well, to cover 6 patients at a ratio of 4:1, we need to have 2 nurses on staff, right? And so that's what that blue bar goes up to 2 staff. And so what we can do is think about, okay, given what I know about my day tomorrow or my week next week or my month next month as volumes are changing, how many staff do I need to plan to have on? And so I'm probably going to look at this and say, okay, well, I probably want to at least staff for average. On occasion, maybe I'm going to want to staff a little bit higher than that, right, if I know that it's going to be a rough day. And then I can look at this and use this to project, okay, well, what's my worst case scenario? Well, at 10 o'clock, I might need 6 staff on. I need to make sure that I have a contingency plan that says, even though only 4 or 5 people are coming in, I need to know that there's at least 1 more person there so that I have a cushion. If I need them, I can call them in, right? And so I can use this bed occupancy to think about how am I going to actually manage my staff and what are the shifts that people are going to work and things of that sort. Okay, so that's that first approach where we take the process, we look at the results, and then say, okay, well, how do we make sure that how do we facilitate this using staff? Okay, that's approach 1. Approach 2 is where we look at our actual staff as constraints on the system. So if the staff isn't available, we don't let the patient move. Right? This project was looking at an outpatient clinic, so kind of a very different environment. And what we were hearing from the doctors was that the nurses were, quote, never available. Right? I need them, and they're not around. We need more nurses. Right? This was the statement that we were hearing. And so we looked at the schedule, we looked at the skill mix, we looked at the staffing schedules, and said, okay, well, what is their actual utilization? And actually, when we ran the model, the result we got was that our staff were utilized less than 30%. Right? And so, the first conversation that happens is, well, your model's wrong, right? Because the staff are never there. The nurses are never there when I need them. I said, okay, all right, well, so clearly there's something that's mismatched here, but why don't we take a minute and do some observations? And what it turned out to be the case is that actually the model was correct. The staff were not highly utilized for clinical tasks. However, what wasn't in the model was all of the other low priority things, the administration, the phone calls, the extra paperwork, the planning for tomorrow, all of those other tasks were pulling our nurses away from the really important clinical things that they needed to be doing. And so because of that, they were not available, right, because they were distracted doing other things. They weren't in a place where the physician realized that they could be interrupted. And so we were able to kind of break out the roles and responsibilities, reassign some tasks, find some ways to minimize the amount of non-clinical work that these folks were doing, and kind of release some of that capacity back to the important clinical work that they actually needed to be focusing on. Okay, so this was a really interesting finding because actually we got midway through the modeling process, got this result, and actually had to stop, go back and do additional observations and find out where the flaw in our logic was, right? And look for that gap. Okay, so that validation process was really important. The last model I want to talk you through really quickly was actually a procedure clinic. So the way this worked, the staff would come in, they would admit the patients would have a workup, they would go through their procedure, and then they would be discharged. And given the growth projections for the clinic, and given the patient delays, because patients were experiencing quite a bit of wait time in order to get in for their procedure, we looked at, did the math, and realized we needed to be able to handle about double the number of patients. But of course, we didn't want to add any additional staff if we could avoid it. And so how do you double the number of patients? Everybody's already really busy without adding additional staff. And so this project was actually a combination of both the lean, a lean effort, right? Can we find efficiency? Can we eliminate waste? And a simulation, which we use then to say, okay, is this new process and these new roles and responsibilities that we think are going to work, right, that we've used our lean process to come up with, is this actually going to be effective? Can we test it out in a virtual environment before we go live? And so we were able to actually lay out all of the individual tasks and then play with different scenarios and assign different staff members to do those different tasks and test out those different scenarios until we got the assignments right. And so this is actually just a screenshot of how we look at that in Simulate. What you can see is that, for example, bed prep is done by the LPN, right? And historically, the nurse had actually gone out to get the patient, escort them back to the room. We moved that around. We tested different scenarios and found that actually the LPN should be the one doing that because the nurse had a lot on their plate. And so we were able to kind of walk through all of these different activities and see who needed to be doing what. Okay. All right, so those are three examples, three very different kinds of operations, three very different approaches to what the simulation actually looked like, but all really focused on how do we solve the staffing problem. Okay, so that's the different approaches. I just want to give you a brief how-to on a couple of different features in Simulate so that you kind of have these for reference when you're going out and you are actually building your own models, you know, kind of what you're looking for and how to do some of the things that I just mentioned. Okay, so I'm just going to walk through a couple of these really quickly. And I'm actually going to flip over to a live model. Okay, so this is just a simple clinic environment, right? Our patient comes in, they get their vitals taken, they do some sort of exam, and then they're discharged by the doctor. Some of them go to have a little bit of education, right? Maybe it's a diabetes clinic or something like that. And then the room needs to be turned over before it can be released and used by the next patient. So fairly simple process. I just want to walk you through a couple of different things that we've done in this model. This is just a sample, but that you may want to use yourself. Okay, so one of the really nice features that I believe was actually a 2014 feature, if we go to our data and roles, we can look at our resource schedule. This is a really great way to be able to manage all of my staff and their availability in one place. And it also allows me to think about how my shifts overlap, think about, you know, lunch breaks and other things that are going to consume time, right, and take away availability, and add a little bit of detail without having to do a lot of work, right? So it's a pretty efficient way to build in a little bit of availability constraint into the model. What we can see across the top is just our different members of staff, and down the left-hand side there we have the hour of the day, and we put in their availability. Okay, so in this case, I've got two techs. Both techs are going to take, in an ideal world, right? We've followed our rules, and we are going to give both of our techs an hour off for lunch, and so that's why we see this break here. Our nurse practitioner, one of them is busy in the morning. Maybe they have a different assignment. They're only going to come in the afternoon, and so we have one available in the morning and then two running in the afternoon. Okay, so we've got a little bit of different availability issues going on, and we've just been able to update those numbers here. Okay, so that is our resource schedule. That's going to allow us to play with availability really easily and quickly. The other thing that I want to mention is actually thinking about how do we use staff. So as you probably know, when we go to select or assign our resources, we click on our activity and we open up our resource dialog, and we can add all of our resources up here. Okay, so normally these are all the resources that are required, and down here what we've actually done is select by label. Each of our patients is coming in with a certain level of acuity or a certain type of exam that they need, and then we're able to assign patients with who need to go to the doctor. Some can go see the nurse practitioner, and others just need to go see the RN. Maybe they have, need allergy shots or something like that, very quick, very easy, and they're going to see the nurse instead. So we're actually helping everybody to work to the top of their capabilities, and we're kind of distributing those patients according to their needs. Okay, we do that using our resource by label. We also do have a few activities that may need a pooled resource. And by that, what I mean is, maybe I'm supposed to do this, but when I'm really busy, you're going to back me up. Right? And so we have this kind of shared responsibility that maybe I'm primary, but you're going to help me out if I need assistance. And so we've actually created an escort pool here, and we can just go in and assign the resources to this pool. In this case, who's going to escort the patient back? Well, it should be the tech, but if the tech is running like crazy and it's a bad day, the nurse can go do that as well. Right? So if the tech isn't available, the nurse isn't going to sit and wait for the tech to go get the patient. She's going to go do it herself. Okay? And so we can share responsibilities that way. And we can also adjust our timing. So maybe if we're thinking about something like vitals, my nurse practitioner, she's really efficient at it. The nurse is going to take just a little bit longer. We can adjust timing as well based on who's doing the activity. Okay, so pooling resources is just a great way to kind of mimic the real life situation, because very rarely is there something that only one person can do. Right? Oftentimes we have a backup plan. And then of course we're interested in our results, and so we can say, what, maybe I'm interested in my nurse, and I want to see what her utilization was, what she spent her time doing. So we've got a pretty highly utilized nursing staff right now, 85%. And on average 2.6 out of the 3 or 4 nurses who are available were actually busy, right? So we're keeping them pretty active. Okay, so that's good to understand kind of what's going on in their life. And then lastly, this is a feature that probably very few of you have seen. I just want to mention this because this is actually a new 2015 feature, and this allows us to look at our interval results. Okay, and what that means is actually looking at our results, not just, the nurse is 85% utilized, but she was really busy from 8 to 10, and then she had a little bit more time, 10 to 12, and then things got crazy in the afternoon. But I want to be able to understand some of those results at a more granular level. And I do that from my results manager. So time interval results is down here. I can set up my options and say, you know what, I want to add a couple of metrics here. I'm also interested in tech utilization, and I want to measure these values every 60 minutes. Okay, I've done that. I've added that to my list, and then when I run the model, once I've run it, I actually get a nice spreadsheet that has the interval. So from 0 to 60, okay, that's the first hour that my model was running, so from 9 to 10 on Monday morning. The average patient time in the system, 41 minutes, right? So they were really speedy that first hour. Patients got through really quickly. 100% of my patients got through in under an hour. That's great. And my nurse utilization was pretty low, right? Okay, the next hour, things were getting a little bit busier. Patients slowed down. It took them just a little bit more time to get through. A couple of patients didn't make it through in under an hour. My nurse utilization went up. right? So I can actually break down these results, put them into some nice charts, really understand a little bit more of the nuance of how my system is operating. Okay? So lots of really great things that I can do with this new feature. I'm really excited to see some of the models that are going to come out and be able to use those results. So there was a quick tour of some how-tos, right? So these are the basic features that you would need to implement those 3 models that I just walked you through. So just wanted to give everybody kind of a little bit of perspective on how to actually do that. And with that, Claire, I think I'm going to send it back to you.
Thank you very much, Brittany. That was great, and I hope people who are using regularly found that useful. It's a real deep dive into what you can do at an operational level. I'm going to jump out again and look at the sort of big picture again, so looking at the typical questions that workforce planners are asking, which is, are the right skills available to meet demand when I need them at a strategic level, so not so much at what Brittany was talking about on a day-to-day level, but overall, how many nurses should we train now to ensure skills are available in 5 years? If they're not available, do we need to recruit from another region? So back out to those more strategic questions. And I don't know if you're familiar with state charts, but we've built a very simple state chart model to simulate our workforce, and I'm just going to flick over to that now. So this is the live model. I've set it to run for 5 years, and what we've got is new employees coming in, and we've set them up to come in every 60 days, so you could set a distribution around that. And we've also got a working population which starts with 100, and the new employees come to that. And as they transition out of that stage, it could be because they leave the organisation. So we've got, again, a likelihood of leaving the organisation. We've also got the likelihood of people taking annual leave, of retiring, of becoming sick. So all of the things that could make our workforce available or unavailable, we put into this model. And then what we can do is to run that model over the 5-year period. So you can see our staff availability graph building, or in this case reducing actually, over as time goes on. So it's a very simple model which you can, if you wanted to create age bands and look at those specifically for particular types of groups of workers, you could very easily build that into this model. And it was the thing that we were thinking is perhaps missing from some of the work that's being done on workforce. So if you're redesigning your service and you want to change it, and it's the sort of radical change that we were talking about in that first example, where you're trying to look after people outside of hospital, it might look like a great idea, but if you've got a reducing workforce in that particular group of staff, then you're going to need to think about how you change that. And it might be about understanding that you're going to be able to close a ward in your hospital and you could retrain those staff. It might be about retraining staff, making sure that you've got enough people learning those skills of highly experienced nurses that can replace the ones that are going to be leaving your workforce. But essentially what you're wanting to do is to match the demand and supply. And so, of course, you wouldn't necessarily be doing this if you're working at a very local level in a healthcare provider. But if you have an overview of the system, so perhaps you're working across a health economy, you have responsibility for the whole of that economy for your population group, and you need to make sure that your service is going to be covered wherever it is, or you're responsible for managing education and training for healthcare staff, then it is the kind of thing that you want to be able to match the service redesigner's view of the world. And the question here is, what if all providers decided to adopt that primary care locality hub concept for a region? And in that first project that I talked about, that's exactly the question that they're asking. So what we can then do is to model that service for that one locality with the 5 million population, and get some of the results out which would explain how many specialist nurses we might need in 5 years' time, and understand whether those nurses are going to be available to us. So that's kind of a quick overview, really, of all of the different ways that we could think of that you might want to model workforce questions for planning purposes. So we wanted to open it out now for questions. You're very welcome to ask them now using the chat panel, or indeed you can continue the discussion on the LinkedIn side. So I'll just pause for a moment to see if there are any questions.
So, Claire, just the 2 questions here that have come in so far. The first was a failure of my part. Somebody asked what an LPN is. I believe it stands for licensed practical nurse, something to that effect. It's essentially a stepping stone, so somebody who has had some nursing training, who can take vitals and do some basic activities, but isn't a fully registered nurse. So it's kind of an in-between a tech and an RN. So that was my...
Healthcare assistant in youth. We're doing some translation now because I know we've got people both from the US and the UK on this webinar listening. So healthcare assistant probably from a UK perspective.
Yeah, okay, great. Came in really trying to figure out when they should be modeling strategically versus operationally, and how you tell kind of what it is that you need to be modeling. How do you distinguish the two? Claire, do you have some thoughts about that?
That's a good question. I mean, my perspective on that is that if you have a big question that's a significant redesign of a service, it's worth doing a sort of big picture change, model of the change, a bit like we did with the overall population. I think that's worth doing, because what it does is it enables you to test out some of the assumptions. If you find that you're going to run into trouble early on because you know you have a workforce issue, or actually if you only look at, in that case of primary care locality hubs, if you were only going to manage alternatives to unscheduled care, actually it wasn't going to be a huge service, and the person who was delivering it would have to do other things as well. You wouldn't be able to set it up as an individual unit. So there might be something about the threshold of activity that you'd be expecting for your new service that might make the service that you're planning unsustainable, because you're just not going to get enough activity to make it worthwhile. So there are some big things that you might be able to rule in and rule out, and also get your education providers engaged with at an early stage so they can see what you're thinking about. And you might do that first before you get into the more operational, granular questions of how you're going to run your new service. On the other hand, if you've got an existing service and you want to make that more efficient, and it's an operational day-to-day, I would dive straight into the detailed operational model. That's my thoughts. Brittany, what do you think?
Yeah, I would absolutely agree. I do think one of the things you just said that I'll just point out is that a phased approach is really probably what you need when you're thinking of. So let's say you're opening up a new surgery center, right? When you're in that kind of strategic planning mode and you're thinking, okay, well, what services are going to be there, and what is this new facility actually going to look like, and what are we going to do there? That's when we do that kind of strategic level, and then we can kind of add detail or build additional models as we go. So when we get to the point where we are, say, a year out from actually opening, right? That's when we need to think about, okay, so how many FTEs do we actually need, right? And then when we get a little bit closer, we're thinking, okay, well, what shifts, 6 months out, we're starting to hire people. What shifts are they going to work? Are they going to work 8-hour shifts, 10-hour shifts, 12-hour shifts? And that's kind of that next level of detail. And then when we get close to the date, it's like, okay, so who's going to do which task, and really how are we going to divide and conquer and get to the nitty-gritty details of the operation. So I almost think you kind of stack the models together as you go through the process of like launching a new facility or even doing a service redesign.
Yeah, thanks, Brittany. Any other questions?
So the other question that just came up was, what are some of the biggest challenges with staffing that you've seen kind of in your work? I'm assuming that's kind of what kind of projects have you worked on that have been kind of interesting or unique?
Ooh, yeah, that's an interesting one. I think one of the challenging things is looking at the skill mix and trying to work out what types of staff. There's a temptation, I think, when you're modelling, is to almost model a day in the life of an individual member of staff. How much time they're spending doing a particular task when they could be doing something else. And it's a bit the example you had when the staff were never available for the doctors. And as a modeller, I think the trick is to work out how you get some answers to that as simply as possible without necessarily having to model absolutely everything that's going on, which is very time consuming and doesn't necessarily get you the results that you want to get. So you can dive into all sorts of details, and I think one of the big challenges at the moment is where people are thinking about skill mix. So they might be thinking about a new service and saying, well, actually, how many of a certain type of staff can I get to carry out this particular part of the role, but I really need a very senior person to deal with another part of the role. And what that really requires is not necessarily a modeler. It's somebody who understands that you can divide the specific tasks of a daily unit, if you like, and patient needs into and set that against the competencies of the staff to deliver. So, for example, we did a project looking at a community nursing team on a day-to-day basis, and we needed to take into account the acuity of the patient, the priority of the patient, and whether staff within that team were competent to deal with individual patients' needs on a particular day. So if you had a patient with wound care needs, did you need a tissue viability nurse to go in and provide that service, or could the healthcare assistant do it? If the tissue viability nurse wasn't available, what's the knock-on impact for the patient of somebody who is less qualified to do that job of doing it? Obviously, they need a service, but are they likely to stay longer with that team because they haven't had the most skilled person dealing with them? And trying to have all of those parts of the problem dissected and bring in the kind of clinical governance part, if you like, of the question, I think is really important. And it's very much the sort of question that people ask when they're looking at the expert at the front of the queue. So when we're looking at having the emergency care physician at the making the decision at the front end of the emergency department and how that affects the throughput. So it's being able to match the competence and the skills to the needs of the patient at the point when they need it. I think that's the tricky bit, and it really does involve a number of people in that conversation, not just the modeler.
Yeah, oh, absolutely. It's interesting you say that, because I guess you kind of, and traditionally this is what we see, right, is we see the modeler being the person who has the technical expertise, and then we have the clinician or the administrator who has the actual knowledge of how the operations function and how the clinical process flows, and that those tend to be two different individuals. But I guess I would just point out to the group that is an assumption about our own, if we wanted to model our own staffing, that those don't have to be two different skill sets, and actually sometimes we see the most powerful conversation happening when somebody who has the operational expertise also getting into the modeling itself. I think that's really where we get a lot of value. And I think, Claire, you've worked a lot with Scenario Generator, which is kind of a simplified interface from Simulate, with the intention that you can bring people who don't necessarily have as much of that engineering hat, technical hat, but can still do great modeling. Do you agree with that?
Yeah, that's interesting. I mean, there was a University of Southampton did an evaluation of the users of Scenario Generator, which was intended for, not, as you say, not necessarily engineers. And what they found was that some of the most successful users were managers who didn't necessarily have the modeling skill. They weren't analysts, but because they understood the system, they got a huge amount from the model. So I always think that's one of our challenges as an organisation, is trying to make sure that our tools are intuitive enough so that the people who really understand how the system works, because they're working it day to day, but don't necessarily have that engineering background, can make the decisions using these kind of techniques.
Sure, absolutely. Okay. Well, let me just jump in then and remind everybody that we do have the Simulate group on LinkedIn. So we will post some of these questions up there. If you have any further questions, obviously we'd love to continue the conversation. If you have any suggestions for topics, questions you'd like us to answer, or you would like to present some of your own work, please contact Claire. You can see her address there. And then finally, really exciting and kind of continuing on this staffing conversation, our April workshop will be on the 28th. This is going to be a really interesting case study presented by a gentleman who's been modeling for a couple of years now. And it's a question, they've been doing a lot of work in their emergency room on throughput, right, and trying to make sure that patients are getting through. And one of the issues that they found was that there was a big delay for CT scanning. So a lot of patients came in, they needed to have a scan done, some sort of diagnosis was going to be based on those results, and so there was a huge delay and obviously the effects on the backlog in the emergency room because these patients were taking so long to get into their CT. And the original, as I understand it, the original plan was to actually go purchase a new CT scanner. But when they pulled out their simulation model, actually they looked at the flow and realized that this was actually, a staffing problem, not an equipment problem. And that part of the issue was this non-clinical time, right? The CT tech, the person running the machine, was spending a lot of time in transport and doing other activities, and that if they were able to add some additional staff, they could actually increase throughput enough that they didn't need the new machine. So Todd's going to get into all the details about it, and there's some additional really cool findings that he's going to share, so I don't want to steal his punchline, but it's going to come back to the same staffing question of how do you use your staff, how do you assign tasks, and make sure that you're making the most of the resources that you have. So really excited about our April webinar, so do please join us for that as well. Sign-ups will go up in a couple of weeks. With that, thanks for joining us today, and let us know if you have any questions. We'll talk next month.